On paper, this hospital is nearly flawless. Federal safety grades rank it among the safest in the country. Inspection reports show compliance. Awards line the walls. Its website promises exceptional care and patient-first medicine. And yet, patients here die at higher rates than they should. Not from outbreaks, not from disasters, not from a single headline-grabbing scandal. Just quietly. So how can a hospital be considered one of the safest in America and still lose more patients than average? That contradiction is where this case begins. And it wouldn't stay theoretical for long. When Maria Alvarez brought her father to the emergency room, she wasn't afraid. He was 72. He had chronic conditions, diabetes, heart disease, but he was stable, talking, joking. Doctors reassured her. This is routine. He's high risk, but manageable. 3 days later, he was dead. The death certificate listed a cause that sounded clinical, inevitable. Complications, comorbidities, expected outcomes. But Maria remembered something else. Delays, contradictory instructions, confusion between departments, and a sudden decline no one could clearly explain. When she asked questions, she received reassurances, not answers. No errors were found. Protocols were followed. This was not preventable. On paper, her father's death made sense. In reality, it didn't, and she wasn't the only one who noticed. Months later, a healthcare analyst reviewing public hospital data noticed something unusual. When this hospital was measured by safety indicators, infection rates, falls, medication errors, it ranked near the top. But when measured by mortality, patients who didn't survive their hospital stay, it consistently performed worse than comparable hospitals. Even stranger, hospitals with lower safety grades often had better survival rates. It raised a question no one wanted to answer. Were safety scores measuring reality or just paperwork? The analysts flagged the anomaly, and quietly investigators were notified. At first, the investigation was limited. No raids, no press conferences, just requests for records, charts, timelines, internal reviews. What investigators found wasn't chaos, it was consistency. Too consistent. Deaths were being classified in similar ways. Language repeated across charts. Decline documented early, sometimes before it visibly occurred. Not falsified, just framed. And framing matters, because how a death is labeled determines whether it counts. Investigators paused, because this wasn't negligence. It was something more deliberate. Then came the first internal contradiction. A patient flagged as palliative had no documented end-of-life discussion. Another marked expected decline had shown stable vitals hours earlier. Individually, these meant nothing. Together, they formed a pattern, and patterns don't happen by accident. Pressure mounted quietly until one hospital employee agreed to speak, anonymously. Not a doctor, not an executive, a senior coding specialist. They didn't accuse anyone of harming patients. They described pressure to code precisely, pressure to document decline early, pressure to ensure outcomes align with reimbursement guidelines, not to lie, to optimize, and optimization has consequences, especially when survival isn't the metric being rewarded. Investigators shifted focus, not to patient rooms, but to administrative offices. They traced how mortality data affected Medicare reimbursements, federal penalties, public safety rankings. One department appeared repeatedly in the chain. Clinical Documentation Improvement, CDI. Its job was to clarify medical records. In reality, it had become a filter, and at the center of that filter was one name. Investigators reviewed internal emails, training documents, performance metrics. They discovered that a senior CDI manager had quietly introduced internal benchmarks, targets, not for patient outcomes, for classification rates. Deaths that fell outside optimal categories were flagged. Charts were returned for clarification. Language was adjusted. The data changed without altering a single medical fact. It was legal, but it was deceptive, and it explained everything. When confronted, the manager denied wrongdoing until investigators presented a timeline, internal directives, performance bonuses, email chains referencing mortality exposure. The silence said everything. Federal charges followed, not for killing patients, but for systemic data manipulation that distorted public safety reporting and influenced healthcare funding decisions. The arrest was quiet, no cameras, no headlines, but the system noticed. The hospital revised its reporting practices. Oversight increased. Mortality rates dropped. Not because patients changed, but because transparency did. Families like Maria's never received apologies, but they received something else: validation, that the confusion they felt was real, that the system they trusted was incomplete. If you appreciate evidence-based storytelling that focuses on how investigators think, consider subscribing to the Forensic Detective Desk. New investigation narratives are shared here every day, and if this case made you pause, question, or rethink what you thought you understood, leave a comment below. What detail stood out to you the most? Your perspective might be the missing piece someone else hasn't considered yet.